record, and then I'm going to hit record on the audio separate. And you know your audience that you're talking to. So we are good to go. In 3, 2, 1. Hi, everyone. Welcome to Sandy K Nutrition, Health and Lifestyle Queen. Today with me, I have Dr. Doug Lucas for round 2. We already recorded once last year and recording again, but I'm going to give you a little outline about Dr. Doug. He is a fellowship-trained precision health specialist. He specializes in metabolic health, hormone optimization for both men and women, osteoporosis, and longevity. Dr. Doug aims to address the underlying cause or causes of chronic disease to improve both health span and lifespan. After finishing his training at Stanford University, Dr. Doug began a medical practice as an orthopedic surgeon. Passionate about nutrition and disease prevention, he quickly became frustrated by the failure of the traditional medical model to allow incorporation of these principles into his practice. He pursued additional fellowship training from the Academy of Anti-Aging Medicine, so A4M, the Academy of Preventative and Innovative Medicine, and Wild Health. His passion is working with patients looking to optimize their health through a customized approach based on genetic data, extensive evaluation, and in-depth lifestyle examination. And today, our discussion is going to be all about those knees and hips at midlife and beyond, and why. We're going to really dig deep on this topic because we all, I'm 53. Everybody knows somebody who's got hip issues or knee issues. So it's a really important topic. And with that, welcome, Dr. Doug.
Thank you, Sandy. So happy to be here again.
Yeah, I'm happy to have you. Last time we talked about osteoporosis, which, if you haven't listened to that one, definitely go back and listen to that one because it was such a great recording. And today we're going to hone in on this whole knee and hip issue. So, Dr. Doug, tell us a little bit about your background.
Yeah, well, thanks for that long description of my training. It's I think it really helps to understand what this perspective is going to be from, which is that of an orthopedic surgeon. Even though I don't practice in that space anymore, I did practice as an orthopedic surgeon. We did surgery. I did thousands of surgery before I finally left the traditional medical model and pursued my own practice and my own business. And so, my background at doing these surgeries, helping people with dealing with the pain of arthritis, the sequelae of injury that then led to arthritis of not only hip and knee, but also ankle. I did a lot of foot and ankle in my practice. So ankle arthritis is a funny topic too. But if you kind of put them all three together, hip, knee, and ankle, they all kind of fit into the same box, which is it's arthritis or pain of a joint in your lower extremity. And if you are fortunate enough to be able to use your lower extremities, then you have to walk on these things. And if they hurt, then it can really limit your activities. So that's the perspective that we look at this from. And there are all kinds of things that I'm looking forward to chatting about.
Okay. Maybe start with this whole arthritis because I was laughing actually with my mom because we were like, remember back in the day, they used to call it, oh, I have rheumatism. Okay. I don't know, you're younger than me, but when I was growing up, I had my godmother, she would say, oh yeah, it's the rheumatism. And it was this saying. So now we have rheumatoid arthritis and we have arthritis.
Sure.
Maybe describe the difference for everybody.
Yeah. In fact, I'll even throw in that third term, which is osteoporosis, because I hear this confusion a lot too.
Okay.
So yeah, so I'm not that much younger than you, just for the record, but no, I know exactly what you mean, because I have patients that would come to me in practice and they would be very concerned about rheumatoid arthritis or osteoarthritis, or they would just say Uncle Arthur, and not know the difference between the two. But I think, I don't know how long ago we really had good blood labs to differentiate between what is truly osteoarthritis or simple breakdown of the joints not really inflammatory in nature, although we'll talk about that, versus rheumatoid arthritis, which is both inflammatory but also autoimmune, meaning that you have a reaction of your immune system that's actually attacking the joints. And that is there's a whole spectrum of diseases in the realm of rheumatoid arthritis, but that's the idea of autoimmune arthritis, which a lot of people will call rheumatoid arthritis. Then separate that from osteoporosis, which gets confused with osteoarthritis. Osteoporosis is not a joint problem typically, and it is a problem of bones and bone metabolism. And people can listen to that last podcast because I think it
Yeah.
was a good discussion of it.
Awesome. Okay. So let's get into the root cause of these joint issues, because today we're going to talk more about the osteoarthritis
Mhm.
side of
Yeah.
things. What are the root causes? Why do some people have it? Some people don't. We've always been told it's a wear and tear
Mhm.
issue.
Yeah, and to some extent that's true, but it doesn't seem to be consistent across the population. What I mean by that is if you look at, let's say, a marathon runner, right? Like there's a tremendous amount of wear and tear in a marathon runner. And you can see marathon runners that last into their 50s, 60s, and 70s, and they're still running dozens and dozens or hundreds of miles in a relatively short period of time, like weeks. If it were consistently a wear and tear problem, then you would be able to say that people that have that kind of activity level would break down their joints, but that doesn't
Right.
necessarily seem to be true. And the opposite end of that spectrum is also very true, which is you see sedentary people that have terrible arthritis that really weren't using them to any appreciable extent. So while we say it's a wear and tear problem, it is not just a wear and tear problem. The truth is there are a lot of variables that go into whether or not you develop arthritis, all the way from genetics. And if you have a strong family history of arthritis problems, then you are likely to be predisposed to that. And unfortunately, probably going to happen earlier in your life unless you can help to prevent it. And we'll talk about how. Um, there's alignment issues. So if your joints are not well aligned, and this again is either genetically driven or it's driven by either injuries or how you're holding or positioning your body, your alignment makes a big difference because the joints are really designed to work in a specific pattern. Or it could just be simply a weight issue. And so we know that people that carry extra weight on their frame are going to put increasing force through their joints. Now, that doesn't mean that those people will develop arthritis, but they have two things going against them, which leads me to the next one, which is inflammation. Now, I already said that osteoarthritis is not an inflammatory problem, meaning that it is not an autoimmune immune system attacking the joint, causing inflammation problem. However, inflammation in and around the joints will lead to increased breakdown of the cartilage, which is the anatomical origin of arthritis. So all of those things can cause arthritis. And then if you mix that again with increased activity, then you take somebody who's overweight, inflamed, has a bad diet, has poor alignment of their joints, and they start jogging, they're going to develop arthritis very quickly. So you have to kind of stack all these things together to understand where this is coming from. And there are probably others that I didn't mention too.
Yeah, I was going to ask you about hormones.
Mm-hmm.
I was talking with a colleague yesterday. We were just talking about thyroid, and she was asking me a lot, because unfortunately I have a lot of experience as it relates to thyroid and not having one, and being hypothyroid also can cause a lot of achiness, like in the joints. So it's just so vast. Joints, there's so many different places that you can look.
Mm-hmm. Absolutely. And one of the big challenges as an orthopedic surgeon when I was in that space is figuring out where are the symptoms coming from. Because we would, the traditional thing, you go to your orthopedic doctor and they take x-rays and they're like, nope, your joint looks good. It's like, well, wait a minute. Like that doesn't mean that the joint isn't dysfunctional or has bad alignment or there's issues with the joint capsule or muscles around. Like there's so many reasons why a joint can cause pain. And the flip side of that is true too. Well, you take an x-ray, man, you got some arthritis. That must be where it's coming from, but not necessarily. I see lots of people that have arthritic joints, hips, and knees that don't have any pain. So really our goal should be, okay, I don't actually care if you have arthritis, it's relative, but our goal should be to get you to a painless joint. And whether that's from, surgery, injections, biologics, other stuff that we're going to talk about, there are lots of ways to get there, hopefully.
Okay. So you said something. Here's a question, because I never really understood this myself. An X-ray will show the bones
Right.
and the joints. An MRI or a CT scan will show all of that plus tendons and ligaments and everything. Like, can you explain, like,
Yeah.
because sometimes could it be you have pain in the joint? Could it be a tendon issue? Like, how do you know?
Yeah. Yeah. Absolutely. And this is where going to the right doctor, or and a lot of times physical therapists and other musculoskeletally directed people can help you here. Um, the X-ray is only going to show bony anatomy for the most part. In If you're looking for arthritis, what you're really looking for is the joint space. And you can imagine if the cartilage, and let's just review the anatomy real quick. So the cartilage kind of lines the end of the bones. I did not do this intentionally, but I have a model
Oh, I like that.
literally just laying on my desk. So let's talk about the knee. So
Okay.
this is the femur bone. And so for those that are listening, I'm holding up a bone. It's a plastic bone. But anyway, the bottom of the femur is the top of the knee joint, right? And so if you're looking at an X-ray, you're literally looking for the space between this bone and the bone below it, the tibia. If you're weight bearing, which you should always be weight bearing if you're looking for arthritis, if you're weight bearing, the bones won't come in contact with each other because there's cartilage in there, or meniscus in the case of the knee also. And if you take an X-ray and that space is thinner, especially on one side more than the other, then you call that wearing of the articular cartilage, and you call that early arthritis. Once the bones start getting closer together and you start seeing other signs of arthritis, like you can see little cysts in the bone or spurs coming off of the bone, that's the more advanced signs of arthritis. And you'd say that person has, advanced osteoarthritis. So you can really tell a lot on X-ray, but again, it doesn't really tell you why you hurt. It just helps with the diagnosis of arthritis. The MRI, if you want to just skip over CT for a second, the MRI is really a modality that looks best at soft tissues. There's a lot of ways to manipulate an MRI, different ways to manipulate the imagery of an MRI so that you can look at different things. So you can actually make it look at bone pretty well, fluid pretty well, soft tissue pretty well. So there's a lot of cool stuff you can do with an MRI, but the downside of MRI is that you can't do it in a weight-bearing fashion. So you're obviously laying on your back on an MRI,
Right.
right? So you can't tell joint space on an MRI, but you can really see things like bone edema, fluid in bones. You can see torn cartilage, you can see torn tendons, ligaments, et cetera. So that's going to be a really good modality to help determine what's happening around the joint and also in the joint. And then CT is kind of in between. We don't use that a lot in the space of arthritis, unless you're talking about operative planning. You're talking about bony anatomy, kind of worried about, do you have enough bone stock? What's the alignment? Do you have bone loss, et cetera? So that's not really a good modality for diagnosing what's going on.
Okay, that was a great description, because you always hear, oh, CT scan, X-ray. I'm like, well, and then you just kind of explained it, the whole, people always say bone on bone, right? It's a term
Right.
that you hear all the time.
Right.
So that's basically where the cartilage is just kind of almost worn, right?
Yeah, the cartilage would have to essentially be gone on both sides of the joint for you to be quote unquote bone on bone. Now, unless I've seen the X-ray myself, I don't really put a lot of credence into that discussion, because people can look at a normal X-ray and think, wow, those bones are close together. That must be bone on bone arthritis, but they don't know what normal looks like. So you really have to understand, bone on bone literally means there's nothing in between and you have bone gliding on bone, which also though isn't necessarily painful.
Oh, interesting. You would think that would be.
Yeah, it's interesting. The cause of pain and arthritis is not really clear. I think the leading thought behind why arthritis hurts is because of the inflammation that results as the joint is wearing in an abnormal way. So you can develop inflammation as a result of the wear. But if you can keep the inflammation down, then it doesn't necessarily hurt. It's obviously not ideal. The bones don't glide on each other as well as the cartilage does. But you can have a painless bone on bone joint.
Okay. I want to go back to the whole genetics thing,
Mhm.
because this is probably the biggest reason people will give. Oh, well, my dad has it, or my grandfather had it. Do you know, like, is there a stat? Like, my father has arthritis.
No,
So,
So the lineage seems to be pretty clear that if your family has it, if you have a lot of people in your family that have it, it's likely that you'll have it. But what we don't know is what is the SNP or the polymorphism, the little
Right.
difference, right? I can't point to a SNP and say, well, that's the arthritis SNP. We don't have that information because there's probably a lot of them that would lead to it. And this is where genetics it's a cool space, and we run genetics on our patients, but there isn't a genetic SNP that I can point to on our report that says, oh, you got to be careful of this arthritis. We don't have that information yet. So we say genetics, but it's really more family history that's going to lead you down this road. But is it the arthritis, or is it the family history of diabetes, or the family history of some kind of autoimmune disease, or
Yes.
like the family history of obesity? All those things are relevant and part of the discussion. So which is it? And we don't really know the answer to that.
It's almost like this tangled web. And trust me, I've gone down that rabbit hole so many times. I've probably done at least 10 different genetic tests.
Mhm.
And, I can pinpoint this and I can pinpoint that. And it goes so much deeper than 23andMe people. Trust
Yeah.
me.
Oh yeah.
I mean, you can use that raw data from 23andMe, and that can be useful, but it's pretty amazing. But okay, let's get into the average age, because you and I kind of mentioned it beforehand. What is the average age? Because hip replacement, isn't it a little bit younger than
Yeah,
knee?
but only by about a year at this point. So I
Oh,
actually I
okay.
did a little research just leading up to this because I haven't looked at these stats in a while. My practice was always a little different because ankle arthritis, which is what I replaced more, ankle arthritis, it happens earlier than even hip and knee. But it kind of goes in that order. So knee, hip, I'm sorry, ankle, hip, and then knee. So ankle earliest and then hip and then knee. And that's not necessarily because the arthritis happens earlier. I think it's more because once your hip is shot, you're very immobile, and it's very painful for those that have had hip arthritis. It is extremely challenging. Knee arthritis, you can kind of get away. It's easier to do injections, and you can kind of kick that can down the road a little bit. So right now, replacements are happening a little bit earlier in hips than they are in knee, but they're both about mid 60s. And that's the population average in the US, at least.
Okay. Now, you mentioned ankles. What do you even do for ankles? Like, you can't replace an ankle.
You
So,
can. No, you can. There's two options. And I know this isn't our primary goal today, but
no.
just a little primer on ankle arthritis is that it is every bit as debilitating as hip arthritis. Um, it's such a small joint that it is a tremendous challenge. And so historically, if you go like 25 years back, the answer was to fuse it, which is an okay surgery. In fact, the outcomes from a pain perspective are really good, but obviously you lose all the motion of the joint. Um, so there have been different versions of ankle replacements over the last couple of decades. The early ones
Wow.
failed miserably. The modern generation, though, are pretty good. And so I did a fair number of ankle replacements before I retired, and last I heard, they were all doing well. So it's a good surgery, but you really need a really good surgeon. You need somebody that does a high volume of ankle replacements, because putting it in right is probably the biggest key to keeping it working and making it last.
Yeah, funny. I know, we're talking mostly about hips and knees because that's what you
It's
hear about
way
the
more
most.
common. Yeah, way more
Yeah.
common. Yeah.
But I never even heard of an ankle
Mhm.
replacement.
Yeah, there's ankle replacements, there's elbow replacements, there's shoulder replacements,
Yeah, shoulder.
yeah.
Shoulder. Well, my
Mhm.
son just had shoulder surgery. And
I need
anyway,
shoulder surgery.
yeah, it's pretty nasty, shoulder
Mhm.
surgery.
Yeah, it
And
is.
and just even thinking about replacing your shoulder, like, it's just
It's a big
anyway.
surgery. I didn't do those in practice, but I did them in training. It's a big surgery. Ugh.
Is it? Okay, yeah, but that's not something you would do if you're elderly either, right? Like,
I mean,
you
you
would.
can, yeah, the indications are changing because just like ankles, they had a bad track record early on. The joints just didn't work well. They were unstable. They dislocated. They didn't reduce pain very well. But that's not true anymore. The joints are much more stable. The technology's gotten a lot better. And this is just true across the board for any joint, because the technology that we are getting from the hip and the knee world then can be extrapolated to these other joints. And so, I mean, if you need a shoulder replacement, if you have bad arthritis, then it's definitely worth entertaining. It's obviously a case-by-case discussion. Um,
Mhm.
so I think shoulders are very reasonable. Ankles, I think, are great, and a good alternative to fusion. Elbows, I can't say I know much about them. Same thing with the wrist. There's wrist replacements. I don't know much about those either.
Wow.
Totally different
Wow.
space. Yeah.
Okay. And so what is the success rate of a hip replacement? How long does a new hip last you?
Yeah, it's funny. We in training, we kind of would throw out these numbers like, it's going to last you 20 years. But if you think about it, that doesn't like that data doesn't make any sense, because if you look at how frequently we're replacing the replacements, we have a new generation hip replacement it seems like every 6 months. I mean, they're just always updating, and the technology is updating so fast that truthfully, we have absolutely no idea how long these things will last,
Ah,
because we can't, I mean, the generation of hip that was being put in 20 years ago is totally different than what's being put in now. So what is being put in now going to last twice as long as what was put in 20 years ago? I have no idea. Nobody knows. And this is one of the issues with any kind of longevity of any kind of implant, is that you don't know, and you have to kind of trust the surgeon, trust the technology, and hope for the best. Now, the good news is that because we are doing such a high volume of these things, that revision, well, it used to be, oh my gosh, wait to do this thing until you absolutely have to do
yes.
it because a revision's terrible. Well, the revision is still not as good as the primary joint, but depending on why you need a revision, the results can still be very good from a revision surgery compared to a primary surgery. So it really comes down to, what is your lifestyle and how much do you need this thing, versus what the risk is. And that, again, it's going to be different person by person. But to answer your first question, which is what is the success rate of a hip replacement? This is one of the reasons why I loved doing them and also hated doing them, is that when they went well, they went really well. Make the results were so good, especially if the surgeon who's doing it uses what's called an anterior approach, which means they're going in through the front of your hip. If you use an anterior approach, you're not cutting any muscles. You're literally just moving things out of the way, doing the procedure, and then letting everything fall back into place. The recovery is so fast. And when it goes well, it's awesome. But when it doesn't go well, it's terrible. But
Yeah.
the likelihood of that happening is extremely low, but it's not zero.
Okay. So let's say somebody who's listening to this already has a new hip or a new knee. What can they do to make it last? From that's
Yeah. This
within
is
their control.
Sure. Yeah. So, like things that are out of your control, like how is the metal implant integrating into the bone, and, bone quality around the implant, although you have some impact over that. But things that you can control, which would be how much are you using it? And then I would say how strong you're staying around it. And then there's that balance between the two, right? So
Oh,
if you can maintain your strength, maintain your agility, not stress it in awkward ways, but you have to use it to maintain your strength, right? So there's this balance. And I hear different surgeons kind of quote different studies to say, well, if you have a knee replacement, you can play doubles tennis, but not singles tennis. You can jog 5 miles, but you can't run. Like those differentiations are so tough because everybody's going to be different. So, I mean, I see guys in their 50s that have knee replacements that are out, skiing backcountry in Montana and in Colorado. And that makes me nervous, but at the same time, why did they get that knee surgery done? It's so they could do the things they love to do. And so it's just this really tough balance of, don't use it too much, but you got it to live your life. So it's a tough question to answer, but obviously not overusing it. Should you be a marathon runner with a knee replacement? Probably not. Hip
mhm.
replacement? Probably not. Should you go walk your dog? Yeah, you probably should, assuming that you have the ability to do that. So it's really tough to find that balance in between. But I think the most important thing that people often forget is to stay strong. And this is true both pre and after replacement. Maintaining your muscle strength is one of the best ways to limit arthritis pain, and one of the best ways to limit joint pain after you've had a joint. Now, again, does that mean that you should be doing, back squats with 300 pounds? Probably not, but you don't need to do that. There's no reason to do that, even arguably before you have knee arthritis.
That actually makes so much sense because my trainer always says the reason I don't have knee issues is because I have extremely strong quads,
Hmm.
right? And so everything supporting the knee is strong. So I'm not, so I love that you said that because it's almost like there are ways in which you can work out the supporting tissue and area, right? Does that make sense? You're
Totally.
working
Yep.
that out to make that strong, so it's gonna have a positive effect on that knee replacement or that hip replacement.
Yeah, think of it again. This is true both pre and post surgery. Think of it like this, where if you are weak, if you have bad alignment, you're really relying on the joint to do more work. Whereas if you're supporting the joint with the musculature, the muscles are doing the work, not really the joint. So you're kind of offloading that work from the joint. Now, you could also argue, though, that the other benefits of exercise, the reduced inflammation overall, likely reduced weight, all the other metabolic impacts of exercise are going to also then improve your joint feel and likely function. So it is just like an upward spiral, right? The more you can do, probably better, but there is a ceiling at some point when you're doing too much and it starts to break down your body.
That makes a lot of sense. Okay, let's get into alternative treatment options, which
Mhm.
everybody likes to know. What can I do? Okay, I know I have a problem with my hip or a knee issue. What can I do now?
Yeah, so this is the space I'm in now, right? So I don't do
Yes.
surgery anymore. My practice is all through telehealth. So all I do is just talk to people about what their options are. And there is a time in which people get things replaced. And I have a couple of patients, this year. I had two that had a hip replacement, one had a knee replacement. And the great thing is being able to talk them through it, kind of how to prehab both physically and metabolically. Let's get your body just ready to do this, and then help them through the surgery part. So it's kind of fun because I know I've watched so many people go through these surgeries. But as far as preventing them, I think let's talk about, if you've had discussions in the past about PRP, cortisone. Do you want to talk about those things?
Yeah, you know what? I think it's important to have just lay it all out in this
Sure.
conversation because they're all important facets to,
Mhm.
that whole preventative medicine generation, right? So I think it's important to talk about it. Yeah.
Yeah. So if you go to your doctor, your orthopedic doctor, for example, and you have knee arthritis and you're not ready for a knee replacement, or they don't think you're ready for a knee replacement, they're going to probably talk to you about one of two injections, one being a steroid injection, which is just a cortisone or some form of steroid that goes into your knee or hip. Although knee is done in the office, hip is generally not. And it basically knocks out the inflammation. And this goes back to that conversation of where does the pain come from arthritis? Well, the steroid injection doesn't do anything to the arthritis. It just knocks out the inflammation. And if you've had one of these injections, you know that the pain typically goes away reliably for at least a few weeks, hopefully a few months, hopefully several months if possible. So that's a reasonable thing to do. But the downside of that is we know that those steroids are also toxic to the cartilage cells. So if your goal is to put off surgery for a long time, then you really should limit or avoid those things if possible, because we know that you are probably hastening the development of arthritis. Now, if you know that you're going to have surgery, like I'm going to have surgery in my shoulder in the fall. So I'm not afraid to put an injection in my AC joint, which is this joint at the top of the shoulder, because I know that I'm going to end up having surgery on it and it's going to go away. But if my goal was to kick the can down the road for the next 20 years, I would not recommend using a steroid and look at some of the other less toxic things. So,
Can I just ask
yeah.
you a
Mhm.
question about that? Because
Mhm.
you hear about people doing cortisone shots all the time. Like,
Mhm.
what are we talking here? Like, can I have one and I'll be okay and I can get away? Let's say I'm going on a golf trip, Dr. Doug, and I just
Yep.
want to kind of stave off that pain while I'm golfing, but I'm only going to do one this year. And I don't
Yeah.
plan on doing them in the future. Like, how many are we talking before it really degrades the joint?
People have kind of all kinds of arbitrary numbers that you put out there. I think, for the foot joints, I would say like three, should be your limit. But that said, I had people with lymphoid arthritis that I did injections in, once a month, because they weren't good candidates for surgery or whatever reason they
Oh,
didn't want to have surgery. And we knew that the joint was already shot. So why not? And there are other reasons that are specific to the foot. But in the knee, there really isn't a limit, but at some point they're also not going to be as effective. So you're going to
Okay.
continue to impact the joint to the point where they don't work anymore, and then you're kind of forcing your hand. So it is kind of tough. How many can you do? There's no hard number, but you could also
Okay.
consider some of the other options. But
Okay.
if you have this big trip plan, for example, I would say they would come to me and say, well, I'm going to go, hike this trail in New Zealand or in Europe or something. I'm like, great, let's get you in the week before, let's get you shot up so that you're, relatively pain-free during that trip. And that usually
Okay.
works pretty well. So it's a
Okay.
reasonable, again, it's a crutch, doesn't get to the underlying cause of the problem, but it's more about lifestyle.
Okay. Cool. Next option. Next.
Next. So if you refuse steroid or you want to try something different or steroid doesn't work for you, then the traditional medical model is going to give you what is basically like a motor oil for your joint. So this is called a viscosupplementation. There's a couple different versions of this on the market, but basically it is like a thick lubricant that goes in your joint. It is FDA approved for the knee. I think it might be for the hip. I didn't do this in practice, so I don't know, but I think maybe it is for the hip. It is not for the ankle last time I checked. But basically what it does is it just goes into the joint and it acts again as a lubricant. It's like a motor oil. It doesn't work like the steroid where it's knocking out inflammation. It is literally working to improve the arthritis. Again, it doesn't make cartilage grow, but it is improving the glide of the joint, which can help the joint over time. And the literature is pretty good. If you look, compare these things to steroid, their results are about the same. There is probably less risk to the joint with these, but there is a small chance of an allergy to some of the components of it. So some people don't tolerate it, but it's a reasonable thing to do because there's no limit on how many of these you can do before you have surgery.
Is that like hyaluronic acid?
Right. Yeah.
Oh, okay. Yeah, I've heard of that. Okay. So then another option, what would be next in kind of in
So then you
line?
start getting into the biologic space. And so this is where you start hearing words like PRP,
Yeah.
stem cells, and this is where the research gets a little murky. And so PRP is getting more common in a traditional practice. We've been using PRP in orthopedics for decades, but generally we used it more in the operating room. We would pull it out of like the iliac crest, which is up by the hip, and you would mix it with stuff and you would put it in different areas of the body. But there was a move really by the non-surgical folks who started using the same technology in the office. And so then the orthopedics kind of captured that. You can get this done in an orthopedic office and all kinds of other, longevity, anti-aging, pain medicine kind of scenarios. The thought behind PRP is that platelets have really cool kind of anti-inflammatory and other growth factors. So platelets in different types of I don't know how to describe this. When you mix PRP, you're really just taking the blood. You're taking a section of the blood after you spin it down, which is high in platelets, so platelet-rich plasma, PRP. There are different ways to do it and different things you can include in it. But let's just say that platelets have really cool growth factors in it and are anti-inflammatory in nature. So when you use those in the joint, there is some thought that you're going to improve the arthritis. I don't think the literature really supports that, but they do have similar or slightly improved, depending on which studies you look at, benefit in the knee. I'm not familiar with the hip literature, but in the foot and ankle, it's really not any better than steroid. It is generally cash pay, insurance doesn't cover it, and it can be
Yeah.
very expensive.
And painful. I had it done.
Yeah, that too.
I had it done in my it wasn't in the ankle, so to speak. I guess it was more for the tendon. Yeah, because I
Mhm.
had a chronic Achilles tendonitis.
Achilles, yeah,
Yeah.
that's a good place for it. Mhm.
It actually worked, and I
Yeah,
think it's been 6 years, and,
nice.
it's been good. But isn't it only as good as your platelets are? Like,
I
like
mean,
what
I don't know why you would have bad platelets though.
I
You
don't
know,
like, I mean, growth factors
yeah.
is what I'm referring to.
You're generating this inflammatory, because it is inflammatory, this inflammatory and healing kind of milieu of all these factors, and we don't really know what all those factors do, but we know it if you just stick them all in one place, it does good stuff usually. And the Achilles tendon is a great example. Plantar fascia is another good example in the foot and ankle arena where we can use these and stimulate a healing response. Because otherwise, for the Achilles, we got nothing. I can't stick a steroid in it because we'd rupture. We would risk rupture.
Yeah.
And other than that, you're talking, let's do therapy, let's do the boot. You probably went through all these things, right? So,
It
so
sucked.
PRP is a good choice for that one, and it does hurt. I haven't done it myself, but I've done
Oh,
it to a lot of people.
oh, really?
It
You've
does
had it
hurt.
done?
Yeah, it's
It
it's it's painful.
hurts.
Yeah, I know. Watching people jump
Yes.
off the table because there's no space. You're literally you're sticking that needle in there and you're literally splitting the fibers of the Achilles tendon.
Yeah. It was kind of ugly, but it worked. So
Yeah,
I
that's great.
I'm good with that. But okay, so but it doesn't so PRP doesn't actually help you to grow cartilage, even though there's
No.
growth factors in it.
Yeah, it would be really great if it did,
Yeah.
but I don't think the research would support the idea that it does. So then that gets us to stem cells.
Yes.
So I think it would be really cool if stem cells did. I've not seen any literature that supports it, but some of the challenges around stem cells is that ethically and legally in the US, we're not, and I think Canada too, we're not allowed to use them. And we're not allowed to do research on them. So we're really stuck because you sort of fall into this, well, where are those stem cells coming from? And then you get into the neonatal tissue and placental tissue. And it's
Oh,
like, oh,
yes.
shoot. And this is a really challenging topic because, of course, it gets into politics and religion. And that's a challenging space to have a rational conversation.
Yeah.
So we are really then relying on other countries that are kind of pushing the needle on this, like Peru, and South American countries. There's some like islands, there's companies all over the world that are in these kind of culturally protected places, and maybe doing things that people just don't know they're doing. But I think the promise is there, but it's going to be a really challenging hurdle to get these things globally available.
Yeah, I recorded a show. It hasn't come out yet, so I don't want to give too much away, but on stem cells and exosomes
Mhm.
using placenta.
Right.
So, I mean, our stem cells are kind of only as good as they can get, when they're younger, and exosomes, but so yeah, that
Yeah.
I think it's kind of an interesting area for sure. And I think that personally, that's just totally my opinion. They should be available if it's done all ethically and
Yeah.
above board, right? Like if somebody wants it. So anyway, let's move on to, because we don't want to get into the whole ethics side of it here. Let's move
No.
on to other things, like other cool stuff. Like talk to me about peptides. Talk to me
Hmm.
about, okay, what about penticin, which is something I've heard about as well. Like talk to me about
Yeah,
these.
I'm not familiar with penticin. I don't, does that have another name?
Probably. I probably just don't know. I've just heard of this. I think it's something that was used in horses. Anyway, I am certainly not an orthopedic expert. I've just heard of this through the
Hmm.
grapevine. But
Penticin.
yeah.
I have the great Google in front of me.
Oh, that's always good. And you'll
Yeah.
understand it more than I would. That's for sure.
Yeah. I don't know anything about it. So I'm just gonna say I don't know anything about it.
All
Well,
right.
let's
All right.
let's talk about, so when I'm in this space, when my patients have arthritis, they have arthritis pain. The first thing I tell them to really look at is what's happening in your diet, and
Yes.
this is where you live, right?
Yep.
So I love the idea, and I have RDs and coaches that work in my practice. So I kind of lean on them for this, but just reminding people, hey, let's look and see what's inflammatory in your diet. Because if we can limit overall inflammation, then we're going to improve your joint pain. And we see this time and time again in my practice and also my wife's business, which is a weight loss business, which really relies on um, a diet that limits basically everything that's inflammatory to begin with. Um, and we see people come in and they'll say, oh, my joint pain's gone, my back pain's gone, and they haven't really lost any weight yet. And so on my side, I see people that are very quickly getting rid of their joint pain when all we're doing is eliminating things that are likely inflammatory. Is that consistent with what you see in your clients?
Yeah. So it's so interesting because I'm always like, let's get you back to being able to eat everything. And I'm not talking about McDonald's here, people. I'm talking about like eating whole real foods
Yeah.
in a variety of different foods. So
Mhm.
being able to eat those nightshades and those legumes, but there may be a period of time where you got to really limit them. And then, of course, you know this, you got to do some work on the gut. What can you do to strengthen the gut? Maybe you'll be able to reintroduce those back in once you do a little gut work. And of course, with gut, there's always things like, I've been reading a lot about butyrate.
Mhm.
Butyrate is pretty amazing. And then just cutting those offending foods. And just like your wife, she's in the whole, fat loss
Right.
industry.
Yeah.
Often when you cut out some of these offending foods and you try and eat them again, then you're like, oh crap, I can't eat that. Then you actually see what was the offender,
Right.
right?
Yeah.
I find it really amazing when you get that knowledge and then you're like, but wait a minute, I want to eat the eggs,
That's right.
right?
Well, and I think there's such a difference when it comes to things like eggs, versus things like highly processed garbage.
Right.
And so we do get people that, on our side. So we'll a lot of times either if we're not testing, because of course you can test all these things, right? What are you sensitive to, food sensitivities, et cetera. But a lot of people don't want to spend the money or don't want to go through the testing, which is fine. So then you just have to do an elimination diet. And so autoimmune, paleo, or AIP is a really popular way to do that. And that's what our coaches lean on. But that eliminates,
A
everything,
lot.
right?
Yeah, a lot.
It's almost like eating a carnivore diet because you're just basically eliminating everything that could possibly be inflammatory, which is, everything except for meat for the most part. And so then you start adding things back and you get, I love to get people back to eating eggs. I love to improve the gut so they can eat eggs because I think eggs are wonderful.
Yes.
Same thing like plus or minus dairy. Like I think dairy, if you can tolerate it, is great. I think you really have to prove if you can tolerate it, but there are a lot of potential benefits. So those are kind of two of the big ones. But when you start talking about like, can I ever eat, in America, we have terrible corn. I don't know how that is in Canada, but in America, we have terrible
Weird.
corn, we have terrible wheat, we have terrible grains across the board. And people say, well, can I ever eat wheat again? And I kind of look at them like, like I just don't know why you would. I just don't know what the benefit. There's no value in it in your diet at all.
Mm.
And then people look at me like I have a third head or something. And
Yep.
but so I think that there are things that you shouldn't necessarily try to get to be able to eat again. And I'm definitely probably in the minority on the grain side, but I also feel that way about beans. Oftentimes people don't tolerate them. But when you start talking about like, well, you should eliminate nightshade vegetables forever. It's like, well, maybe. But it's oftentimes we can add those things back and then you can have more variety in your diet. Because I do see people that kind of get pigeonholed into a really narrow diet.
Yeah. And then, I always say this too, when people cut things out too long that are good whole real foods, you might not want to eat them every day, but having them once in a while, they stop producing the enzymes to even be able to
Yeah.
break that food down, right?
Yeah.
Like, so dairy is a great example.
Great example.
You go and you cut out dairy for a whole year and then you try and eat it, even though you've done all the gut work and
Oh,
you've done all
it's
that,
it's
you won't be able
terrible.
to.
Yeah.
Yeah.
Yeah. Hmm.
Yeah. So, okay. So definitely, 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 you gotta look at what you're putting in your body. We know this. Everyone knows this. Um, but the key is look at the whole real food diet and then eliminate certain things that might be offending to that whole inflammatory picture that's going on in your body, right?
Yep. Absolutely.
So let's say you have arthritis and it's in the knee, um, and it's really hard to work out
Yeah.
because you are in so much pain. So what do you suggest to those patients?
Yeah. I think some of it is what are you trying to do? I always try to bring people away from what they're usually doing, which is, well, I'm trying to run. Like, well, don't run.
Yeah.
Furniture.
Okay. Yes.
But if they're being rational about what they're trying to do, then you're really steering them towards doing resistance training. So strengthen your quads, kind of like we talked about earlier. The more strain and stress you can put on your muscles, the less you're going to have on your joints. And there's good literature to support that. So really steering them towards resistance training, and then also reminding them, hey, you have knee arthritis, and that's a bummer, but there's nothing wrong with your upper body.
Yeah.
Like you can
Yeah.
do so many things with your upper body, and people would become a victim of their either arthritis or, and when I was practicing, a lot of times their injury, I would see people that would, they'd break their ankle and they would come in and they're just like, oh, I've gained 15 pounds and I feel like a sloth and I'm not, I just feel like I can't do anything. And I'm like, what's wrong with your upper body? Like, go to the gym, crutch
Yeah.
around, do some
Yeah.
work, like you don't have to be a victim of your illness.
Mhm.
So that's
I
probably the
like
number
that.
one, is saying, okay, look, yeah, you have arthritis. Great. People have all kinds of stuff going on with their bodies. Let's just figure out how to get around it.
I love that you said that. I broke my heel
Mm,
when I was 40, and I went to yoga. I did yoga
yeah.
and stretch.
All on one side.
Yeah, like I did whatever I could do, I would do. I had my boot on. So you would have been a surgeon who hated me because I refused to cast and I never went.
I don't mind. I never minded that, as long as I felt the patient understood the importance of wearing the boot. Um,
Oh no,
so there
you would
are,
hate me. I would
yeah,
I
there
would
are,
take my boot off to drive. And
yeah. Yeah, but
that's
then
that.
I used to get really upset when I was early on in practice. And then after a while, it's say, look, all I'm here to do is give you recommendations based off of my training. Ultimately, is your heel. You do what you
Yes,
want,
I know.
right?
I know.
I,
And
I
that's
can
probably why
explain
I
to you the
had
consequences, but
right,
is your heel fine?
no, but see, here's the funny thing. I think this is why I had the issue with the Achilles tendon
Maybe.
on the same foot,
Yeah.
right? I don't
Hmm.
know.
Maybe.
Anyway, so we have to get into supplements because everybody always wants to know, what can I take to lower the inflammatory process and to help with pain and all of these things? What are your favorite things to take?
Gosh, this is a tough one, because when I was in training, it was all about like, oh, curcumin and, like all these things they're just everywhere. Um,
Yes.
and I have not found them to be really effective, like all the turmeric stuff. Myself and in patients, I don't find them to be effective. Have you found them to be effective?
Nope.
Yeah.
Nope. Because, and it's interesting because I read a study, Doug, that said that curcumin over a 3-week period, and I wish I could find it, I'm going to have to look for it, was just as effective as an NSAID. I'm like, I'm going to call BS on that. I feel like there were probably some real flaws in that study because
Probably.
I don't see it. And I've got somebody who had pretty chronic knee pain in my house.
Yeah. Yeah. So, I mean, I've taken them. I don't like NSAIDs. So I do not like, over the counter, non-steroidal anti-inflammatories like ibuprofen, Motrin, Aleve. They are okay in the very short term, but they have negative impacts more than we probably know. And people
Yeah.
overdose on them all the time.
Yeah.
So it used, like when I was in training in orthopedics, we would say, oh, this, you should put ibuprofen in the water. It's going to cure heart attacks and blah, blah, blah. No, it would destroy people's guts, and
Yes.
we would have tremendous negative impact. So I kind of been stuck because I don't like curcumin. I don't like turmeric, obviously the same thing. There are some products that I'll use that'll have things like bromelain or, different versions of ginger. But honestly, I don't have a supplement. We'll talk about peptides in a second, but I don't have a supplement that is the answer to inflammation. I just don't.
No, I don't disagree. And, for me, I always say, listen, if you're in that much pain, you're going to cause some pretty, serious rebound effect in your stress response. I say
Right.
this to my dad, right? But then I'm always like, how do you balance it? So if you are taking the NSAIDs, How do you balance? I remember when I had COVID last summer, I was, down for about 3 days, and I was taking Advil because it's
Mhm.
the only thing that worked. I really.
For like a headache or body aches?
Yes, oh
Yeah.
my god, it was so bad. The aches were
Yeah.
so bad. Tylenol wasn't doing it, but what I was doing on the flip side was I was taking butyrate, I was taking L-glutamine, I was, like, so I was kinda, like, doing things on the other side to try to mitigate the effects of the
Mhm.
NSAIDs and Tylenol, right?
Yeah, yeah, it is.
But it
And
was
again,
short
I
term.
think for short term, it's okay, but when
Yeah,
you're dealing with arthritis, people will say, well, I've been taking 800 milligram ibuprofen 6 times a day for the last 3 years. Like, oh God,
yeah,
please
yeah.
don't do that. It's so tough on your gut. So then I point people towards, okay, well, let's clean up the diet. Let's work on the exercise side. Let's do things that are appropriate. If they have extra weight, get the weight off. Obviously easier said than done. I say that like it's that easy. Um, and then we do talk about peptides now because we are not a brick and mortar. I'm not doing intra-articular peptide injections. I'm only kind of making recommendations for sub-Q and IM things. But things like BPC 157 is really popular for specific joint pain. Injecting them around the joint, not in the joint for my patients. Um, and then also just doing other things that are optimizing the body. Again, it just kind of helps to indirectly treat the joint, which is optimizing hormones, using peptides in other ways, using peptides that are going to help with muscle mass and growing muscle and the GLP-1 agonists and those things. So we really kind of just work around it and try to reduce the inflammation or find the cause of inflammation, which also leads us to gut. So you just like, you can see how this thing just like keeps going and going and going, but
Yes.
I'm generally not directing my efforts right at the joint.
Okay, so then let's say I'm asking you, what do you suggest for pain? Like,
Mhm.
okay, we don't like curcumin doesn't seem to really do much. We know what NSAIDs do. Tylenol, well, Tylenol doesn't really work, so what do
I
we
think
do?
I think Tylenol works better than we give it credit for. And
Yeah.
so, my my wife and my kids, they get so tired of hearing me talk about these things. But if we have pain, most people will reach to anti-inflammatories because it's so ingrained, pain, inflammation. But really, if you have pain, use a pain drug, which is Tylenol is the only really over-the-counter pain drug. And I think it does work better than most people give it credit for. And the reason why I think that is that if you go back to my prescribing days when we were prescribing a lot of narcotics, kind of before the narcotic epidemic really took off, the narcotics that had Tylenol in it were way more effective than the narcotics that didn't. And so, people started getting away from the products that had Tylenol in it because people would overdose on Tylenol because they wanted more narcotic, right? So then to protect them,
Uh,
we take the Tylenol out, and then they're just taking way more narcotics. But if the patients understood that the dose had to be maintained at whatever it is for the Tylenol, they ended up doing better. And so I ended up treating a lot of people, especially as people started talking about recovery and I don't want to take narcotics. I had people that would go through surgery and all they would take after surgery is Tylenol. So I do think it works. I think we don't give it enough credit. And from a safety perspective, as long as you stay under that kind of 4 gram per day, recommendation for toxicity, it's pretty darn safe. I wouldn't want to take it every day forever, but for acute pain, I think it's probably your best choice.
you said something just there about maintaining the level in the body. So let's say if you take Tylenol one day and then you don't, and then you do, and then you don't, it's not going to work as effectively as taking it as prescribed
Consistently.
consistently, right? But there's also things, and I don't disagree because, I mean, when I had my thyroid removed, I had a slice here and I had a couple of lymph nodes. And I remember saying to the nurse, stop giving me morphine.
Yeah.
And I actually went home and just took extra strength Tylenol, and that's it.
Yeah. Yeah.
So,
I really think we've lost in the pain control world, we've lost the idea of What we're looking for is the absence of pain, not the addition of feeling high. Right. So
Mm.
like this is where narcotics have become a real problem because they don't really take away your pain. They kind of take away or change your perception. So you still have the pain, but you have other things that are more powerful potentially, but very habituating. And so we don't, take Tylenol and people say, well, I don't feel anything. And you're like, yep, you nailed it. That's right. You don't feel anything because it's reducing your pain versus taking something that's going to make you feel something different that you feel, like, oh, I feel that. And I feel constipated and itchy and, like dizzy when I stand up. We're like, yep, those are narcotics. And those are the side effects of narcotics.
Oh my God, that's such a huge topic, Doug. I did record a show on opioids, and I actually have a rule in my house. No, we have a no opioid rule, and they prescribe it here in Canada just for getting a tooth pulled.
Sure. Yeah.
So, that's my belief system is, mm, I don't want them in my house, put it that
Nope.
way.
Yep.
Okay. So we kind of ran down everything. Did we miss anything?
I mean, we just touched briefly on optimizing hormones, and you
Oh,
kind of
yeah.
mentioned thyroid. I think it's worth just mentioning that pain is a really funny player. And if things are out of whack, you're going to feel pain more than if they're not. So this is where I love the space of health optimization, because when you look at everything globally, you say, okay, how is your gut functioning? What are your thyroid numbers, your real thyroid numbers look like? Where are your hormones? What are our indicators of immune function looking like? If all of those things are lined up and things are truly optimized, I think you're going to manage pain in a totally different space than if any of those things are out of whack. If you have, depression or other psychological issues going along with it, I think because pain it's so hard to understand from the outside. It is really how you're feeling with it on the inside, and then also how you're letting it affect you. And it's really, really tough. But when I see people, because I imparted a lot of pain as a surgeon, create pain, and watching different people deal with it in different ways is really remarkable. I mean, we're talking thousands and thousands of people that would have similar surgeries, incisions, broken bones, doing things that cause a lot of pain, and seeing this broad spectrum of how people respond to it and what they need to manage it. And so much of it is based off of basically their emotions, their approach, their cognition around it. And it's really tough to talk to people about it because you don't know what they're feeling. And that's absolutely true. But we also know, and I think you would agree, that covering it up with an addictive drug is not the answer.
No. And I like that you kind of mentioned there's even some apps now that help people deal with that chronic pain,
Yeah,
right? Like when
sure.
there's some apps, and I can't remember what they're called, but there's a lot of different things, and I like your approach that you kind of take from all areas to try and, I guess, really, would you agree that you want to put off that knee and hip replacement as long as
Yeah,
you
I think,
can?
yeah, it's a good way to come back around to it. So in some ways, yes, because you don't want to have early surgery knowing that if things go well and your health span and lifespan are great, that you're going to need multiple revisions. Like I have pretty significant knee arthritis in my right knee because of some old injuries. To have a knee replacement now in my mid 40s would really be setting me up for failure in the future, because I know that, if everything goes well with all the stuff I'm doing, I should live a nice, healthy, long life. But that said, is how much is my knee limiting me? Well, I don't run long distances. If I wear a rucksack with more than 30 pounds, it kind of aches, but it doesn't keep me up at night. It doesn't keep me from sleeping. I can lift weight. Like I'm active with it. I can play with my kids. So it's not time.
Yeah.
Now, let's go down the road 5 years. I'm 50 years old. Now, my knee's swollen. I have to ice it every day. I can't run at all. Maybe I can't ride a bike anymore. I can't get down on the ground with my kids. I mean, my youngest is 4. So there's a lot of up and down happening in my house.
Yeah, for sure.
Is it right at 50? Well, it's 50 is still young, but I also know that a good knee replacement is going to really improve function. So it's not unreasonable. It's early, but it's not unreasonable if my health is going to start sliding because I'm not able to stay active. So it is just a really tough decision around when to have it done. And you want to do everything you can to kick it down the road as long as you can, because it's a big surgery. There is risk and they don't always go well. But if you're miserable and you can't stay active and you can't meet your goals and it's affecting you both physically and mentally and emotionally and those around you, yeah, it's worth having that conversation. So it is such a person by person thing, and it really shouldn't be driven by pain. It should really be driven by function.
Mm, I like that. And, I like that, you can try all these other things before.
Hmm.
Um, I'm never against Western medicine and what they do. Western medicine saves lives and everything. But the fact is there's a lot we can do to prevent certain things from happening. Like, I mean,
Yeah.
like try the PRP first, see if it works. Try the hyaluronic acid injections, see if it
Yep.
works, right?
Yep. Yeah. I mean, people will say, if everybody's coming from different socioeconomic areas.
Yeah.
And so people say, well, I can't afford it. And that's absolutely a possibility. PRP is expensive. It's getting less expensive, but it's pricey. Things like stem cells. I have patients, my my well-to-do patients that are traveling to Peru to get stem cells. I mean, that's cool, and if it helps, that's great. But that's, you're talking tens of thousands of dollars, and that's really, really
Lots.
difficult. Um, so it is a challenge, in Canada and the US have different healthcare systems, which I think are probably on the way to being more similar than different.
I think you're
But
right.
it's such a challenge to know where to go. And this is where having a good mind of somebody to talk to who can really rationalize both sides of the equation is really important. And it's so, your clients are really lucky that they have you to talk to about this, because you do get it, the benefits of Western medicine versus, what are the alternatives? Because there are things that Western medicine is not good at, but we can't say that it's bad for everything, because certainly if you get into a car accident, you have trauma, you have a broken leg,
Heart
you have a heart
attack?
attack, right?
Yes.
It's amazing. I mean, the fact
Yeah,
that if I had a heart attack in my house right now, I would be stented in less than 45 minutes at a trauma center is unbelievable.
there you go.
But my patients with osteoporosis who are, just searching desperately for the answer that doesn't involve a pharmaceutical that they don't want to take. The system's terrible at that. So yeah, it's a really tough place to be.
Well, this has been such a great conversation. I love the whole integration picture where you look at everything. I love what you're doing. Please tell everyone where we can find you.
Absolutely. So I'd say the easiest place to find us is just go to our website at optimalhumanhealth.com. We kind of have mirrored practices. So if you're interested in sort of the overall health span longevity, that's where you're going to find that information, which is on Optimal Human Health. If you're interested in osteoporosis, Optimal Bone Health is the URL for that one. So optimalbonehealth.com. Obviously, one links to the other. So just remember one of those if you can. We're putting a lot of information, and right now mostly around the bone health side in our YouTube channel. So if you just look up Dr. Doug Lucas on YouTube, you'll find us. That will eventually also become more anti-aging longevity when me and my team can circle back around to it. Right now, it's a great spot for osteoporosis, and we have a lot of pending material. So we're really excited about that.
Yeah, you have to go check Dr. Doug out on YouTube if you are interested in bone. And like you said, later on, you're going to have more content on there. But I've watched some of those videos. They're amazingly informative. So definitely go check him out. Thank you so much, Dr. Doug. I love
Thank you.
chatting with you always.
Yeah, thank you, Sandy. Really appreciate the opportunity.
Okay, I hit stop
Great.
there. That was so good.
I know you're